So pediatric assessment. Obviously in an hour I'm not going to give you everything you need to know about pediatric assessment, but just stuff that you need to think about as you're doing the scenario. What's probably the hardest thing about pediatric assessment?
We don't deal with them all the time.
Oh, okay, so the size of the patient. The biggest thing is, who just said we don't do them all the time? That's probably the biggest issue. We're comfortable with adults, we're comfortable with elders, you know. Put a kid in front of us and holy crap, get this thing out of here, you know. Generally, people with kids are more comfortable than people without kids. But either way, it's really stressful. Most adults are responsible for what happens to them, or that's kind of the way you feel, you know. We do adults all the time that don't take their medications, you know, put themselves in some spots where they probably shouldn't. So they're kind of responsible for what happens to themselves. Not so much with pediatrics. It's very stressful because, number one, the equipment's all different. We don't use the equipment that often, although it's all the same. It's different because it's smaller. We don't use it that often. When we go to look for it, it's not always where we think it is. Someone else may have used it and not replaced it. We tend not to check out that equipment. Communications with patients, bystanders, and parents can be especially stressful because they all have something to say as far as what they think we should be doing. If you have a kid that's been hurt in a car accident, how many different stories do you actually get about what's actually happened to that kid? And you've got to try to sort this all through. It's not only stressful from our side. Think about a parent. Think about a parent that's got a little kid that's sick. It's really stressful trying to deal with them. You've really got not one patient, you've got a couple of patients because you've also got to settle down the parents and the bystanders who watch this happen. General approach to pediatric emergencies. Really, a lot of it is psychological support and communication. So communication needs to be tailored to the age group. You cannot talk to a 6-month-old. Well, you can talk to the 6-month-old, but the answers you get are probably not going to be sufficient from the 6-month-old. So you'll get your information from the parents. All the way up to probably about a year and a half. Kids who are maybe 2 years old can point, you know, what hurts and they'll point to it, but they're not going to give you specifics. They're not going to be able to say, I'm nauseous, I'm dizzy, you know, my stomach hurts. They're probably not going to be able to give you any specifics about that like we would ask for. So that OPQRST that we would normally do on the adult has to be modified to get what you need. And sometimes you don't get what you need at all. Sometimes you have to go with whatever you find, what the signs and the signs are more than the symptoms. You've got to listen to what they're telling you as well. Because too frequently we ask them rapid fire questions. If there are multiple people asking a 2-year-old questions, what are they thinking? You know, who do I answer? What's going to happen?
They're scared.
Okay, so they're scared. Well, how much information are you going to get once that starts?
None.
You're not going to get anything. They're going to shut down. Okay. Kids, depending on the age group, although even the older ones won't tell you this, but they are. You know. They're afraid of being removed from the family, being separated from their familiar surroundings. They're afraid of being hurt. What's the first thing they think of when they see that ambulance come up? Or when they go to the doctor's office, for that matter?
Needles.
Needles. Am I going to get a needle? You're going to stick me with a needle? That's kind of a normal reaction. As they get older, they're afraid of being mutilated, disfigured. We're talking teenagers. Because some of the younger kids actually think it's pretty cool to show all their friends the stitches they have. But the older groups don't. They're also kind of afraid of the unknown. You're a stranger. What do we tell our kids?
Stay away from strangers.
Stay away from strangers. Don't talk to strangers. Just because I drive up in a maybe not so shiny truck with a lot of lights on and I step out with a uniform and lots of equipment, am I still a stranger? And they've been told not to talk to us. So you've got to kind of break that ice and tailor what you need to get from that kid. Responding to parents or the caregivers. So parents and caregivers are a little different. You get a different dynamic if you go to a daycare center and get people who are just watching the kid for the day as opposed to a parent. Be careful how you ask the parents questions. As a father who took care of my 3 kids, I was really kind of annoyed when people would say to me, when the doc or the physician assistant would say, well, what does mom say about this? What does mom say about that? Mom's not here. You're not getting an answer, And I would have like PA students that would come in and do the exam first and ask me all these questions about what mom says. I don't know. Mom's not here. I don't know. And then the doc would come in, because I knew the routine. The doc would come in and ask me all those questions, and I would answer them. And the PA student would be absolutely livid. And she'd say, I asked him all these. No, you asked me what mom said, So it's very insulting to keep asking what the other parent said when you're the parent that's there. Be honest. If you're going to hurt the kid, say it. I've got to put your arm's broken. I've got to put your arm in a splint. Can you put that arm in a splint without hurting that kid?
No.
What are you going to tell the kid?
Breathe through it.
Well, not just breathe through it. What's the end point of this?
It's gotta feel better.
It's going to feel better. I'm going to try to do it without hurting you, but it might hurt a little bit, but once I put this on, it's not going to move and it's going to feel better. We're going to put some ice on it and we're going to make it so that it doesn't move so you can get to the hospital without it hurting anymore. That's what they're concerned about. So be honest. Can I stick a needle in your arm, an adult, a PD, whatever, without it really hurting? No. Whereas an adult, I might say, when they say, is it going to hurt? No, I'm not going to feel a thing. I can't get away with that with a kid. Because the kid's not going to find that as funny. Maybe the adult won't either, but that's beside the point. The kid's not going to find that funny when it hurts. Okay? So I'm going to tell the kid, yep, explain it. You have to take a little more time. Explain the procedure. Show them the equipment. Take a catheter. Take take it off and say, this is the piece of plastic that's going to stay in your arm once it's gone. The needle's coming out. But once I do this once, I can give you medications without sticking you again, without hurting you again. And once you explain that, they're usually okay with that. It's when you don't explain stuff and it's that fear of the unknown that they kind of freak out. Parents, you got to keep them informed. You've got to keep them, the word the book likes to use is focused. If I have a parent that's off the wall, what happens how's my management ability with the kid?
Lousy.
Yeah, it's lousy. Because what does the kid think? If mom's really upset and off the wall,
Something really bad's happening.
something really bad is happening. So I have to keep mom focused to the point where I've told parents, you can only come in the back if you settle down, because once you start this in front of the kid, I'm not going to get anything done. So that's something that you got to think about as well, how to keep the parents focused. And sometimes it's really hard. Sometimes the only way to keep them focused is to keep them out of the event, and that's really hard to do. Or so in the system I work in, it's an ALS and a BLS truck that go. If that parent is off the wall, they don't even ride in front of the ALS truck. They ride in front of the BLS truck. They ride in the empty truck, because otherwise they're sticking their head through the hole and through the hatch and yelling at the kid the whole way. And I get nothing done. So you've got to kind of settle parents down as well. You've got to think of it as having two patients. Growth and development, probably the hardest thing, and someone mentioned this earlier, look at the age range. We go from infants, newborns, all the way up to 18 years old. Now, granted, when I see a 16 or an 18-year-old, yeah, I'm treating that kid pretty much like an adult. The equipment is all the same. The drug dosages are the same. But when we look at these, children and younger, there's a huge variety of there's a huge spectrum there. This group is either really scared or really willing to play with you. But you've got to communicate with them. The big problem with pediatric doses, for this age range, what's the biggest problem with drugs?
We don't know the doses as well.
Right, we don't know the doses as well. We really don't. As much as I would like to say, everybody I work with knows that, the dose of atropine for a child is 0.02 milligrams per kilogram. They don't. They depend on the Broslow tape. They depend on their phone. I hate seeing cell phones come out on a call. I just do. Stuff that is supposed to be a pleasant experience for kids going to see Santa isn't always a pleasant experience for either the kid or Santa. What does that mean when, we're not coming to take the kid to see Santa, we're coming because there's a problem with the kid. Their experience with us might not be very good at all. So you gotta keep that in mind, okay, as you deal with kids. You can't be rigid when you deal with kids. So if I'm the one it's my right, I'm teching the call, and I know this kid, I'm not interacting well with this kid, what should I do? What should my partner be willing to do?
Exchange seats.
Step in, because otherwise we're not gonna get anything done. If I know that I really suck at IVs on an adult, how good am I gonna be on a 6-month-old? So if I know my partner is better at IV skills than I am, I'm more than happy to let him or her take over and say, why don't you try this so we only have to do it once? For a lot of EMTs and paramedics, it gets to be kind of an ego thing. I'm going to get this if it kills the patient. You can't do that with the pediatric population. They're not going to allow you to. The older group brings a whole different set of issues. They're more like adults. You can treat them more like adults, but their attitudes are different, especially if their parents are around. They don't like to deal with anybody who's an adult, who's an authority figure as a rule. Some of them, and that's not the case for everybody, but a lot of them, they think they're adults even though emotionally they may not be. They think they are. And that age range is really difficult to deal with. They're not always truthful with you. You also can't ask them questions in front of their parents. If you get a 15-year-old girl with abdominal pain, what's the first thing you're thinking of?
Is she pregnant?
Is she pregnant? If I ask that 15-year-old in front of her parents, any chance you're pregnant? What am I going to get for an answer?
No.
Assuming the father figure or whoever the parent figure is doesn't get outraged at me for even asking. So I need to get that kid out of that environment that they're in and bring them into my environment and ask them very quietly, listen, I'm not going to tell your parents. I just want to make sure that I treat you properly. That might be the only way you get an answer. The parents are going to find out eventually. It need to be me that tells them. Okay? General approach to pediatric assessment. A lot of the patient assessment that we do on pediatrics is done without touching the patient. So you've got, and depending on the age range, you've got to involve the caregiver as much as possible. If I have a 6-month-old, who's the center of the 6-month-old's life?
Mom or dad.
Mom or dad. If I take that kid away from that parent and I'm going to just hold the kid and do that assessment, what am I getting done? Nothing. Because as soon as I touch the kid, what's probably going to happen?
Start crying.
They're going to start crying. They're going to start screaming, kicking. As soon as they start to cry, what's my lung assessment?
Good.
Compromise.
Yeah. If they can cry that loudly, they're probably okay. But am I going to get really a decent idea of what's underneath all that crying? Okay, so you've got to keep that in mind. So you've got to modify what you're doing. You want to allow the parents to stay with the kid during the treatment. I will even let the parent, hold my stethoscope and put the stethoscope on the kid's back where I need it to be placed, rather than mine doing it. If the kid is that upset by my being there, I let the parent do it, because the parents are the ones that are going to really control this. You also want to look at the interaction between the parents and the kids. Because if a kid doesn't look for the parent for comfort, there's a problem. And I'm not saying that if the kid's always used to being with mom and now dad is around and, the relationship with mom is better, yeah, they might not go to the father for comfort. But it's something to keep in mind, because that involves maybe there's a potential of some child abuse going on as well, or neglect. Quick scene sizer. Obviously the ever-present body substance isolation. But as you walk in, you can get clues about, the mechanism of injury, nature of illness. And don't go running up to, we find an adult on the ground, we go running right up. Stop a minute, let the kid get used to seeing you, and obviously not with an unconscious kid. Let the kid get used to your presence in the room. Show them that, you're not going to just jump in and do something horrible to them. You don't want to yell at kids, even a kid that's crying. Yelling only makes their crying worse. I had 3 kids. I know what yelling does to kids. I know what yelling did to me. But keep that in mind, speak simply, speak softly to them. And when I say simply, can you ask, so I ask an adult, do you have any abdominal pain? Will I get an answer?
No.
More than likely.
More than likely I will. If I ask a 3-year-old, do you have any abdominal pain? What does abdomen mean to a kid?
Nothing.
Nothing. So you gotta tailor what you ask to that age group. You can't ask a kid, are you dizzy? Because what does dizziness mean to a 4-year-old?
Fun.
Yeah, might not mean anything. So you've got to ask them, does your head feel like it's spinning? Does the room feel like it's spinning? And that gives them, that allows you to get the information you need without the big medical terms. You can turn that into big medical terms when you want to, when you write your trip sheet, but you don't have to do that necessarily with the patient because it's not really productive. The whole assessment pretty much is based on the pediatric assessment triangle. And you can do this really from the door. You don't even need to touch the patient just yet. So appearance, mental status, muscle tone, how do they look? There's a whole lot of difference between a kid that's in mom's arms, grabbing mom, crying, than a kid that's just laying limp without, that doesn't even look up. Kids are very curious. If you have a 6-month-old, as soon as something new pops up, what do they want to do?
Look at it.
Yeah, they want to look at it. They want to check it out. They're interested. Oh, here's something I've never seen before. Even if it's a stranger coming in with all your toys, they're still interested in what you got because that's potential play toys that they can, mess with. So think about that. Think about just how you're seeing this patient. As far as breathing, you look at the breathing, you can see the work of breathing, and we'll talk about more of that in a minute. And skin color, how's their circulation? How hard is it to find a pulse on an infant?
Pretty hard.
Pretty hard.
Yeah, why?
And small. Arteries are tiny.
They're small, their arteries are tiny.
Enough musculature to push the veins up.
Yep, they got a lot of subcutaneous tissue around them. You can't take a carotid pulse on an infant. It doesn't work. You can try the brachial, but even that sometimes is hard to find. So forming the general impression, skin color. Is it pink and dry, pink? Is the color good? Is it cyanotic? Is it really pale? Is it mottled? Is it a mixture of cyanosis and kind of pale? How are they acting? Are they paying attention to their surroundings, or are they really upset? And how do they respond to you? For assessing the ABCs, you want to look. If, as much as I hate to have a kid crying in front of me, what does that tell me about their respiratory stats?
Good. They're moving in.
They're moving air, especially if it's a loud cry. I'm good with the respiratory if it's a loud cry. If they're coughing, if there's not a whole lot of cry, it's a really weak cry, I need to worry about the respiratory component because that tells me that they're not moving a lot of air. As you look at them, how's their work of breathing? Now, in this kind of weather, it's 75, 80 degrees. A lot of kids don't have tons of clothing on. In the wintertime, you might need to peel those layers of clothing off like an onion to get what you really need to see. Because with those multiple layers of clothing on it, you're going to see that seesaw breathing. You're going to see those intercostal retractions. So you need to think about that as well. And how you go about that depends on how good you are with these kids. Because if you start ripping clothes off, they're not going to be too comfortable. You've got to have mom or dad do it, or whoever they're comfortable with. Listen to them breathe. If they're not crying, how are they breathing? What's their respiratory rate? We really are horrible at counting respiratory rates. Everybody depends on that O2 sat. Put the O2 sat on. That'll give me a number. Number's gold. But how are they breathing? Because what's the normal adult respiratory rate? 12 to 20. What's the normal respiratory rate for a kid?
24 to 30.
It depends on the age. So if you have an infant breathing, like a newborn, breathing 50 or 60 times a minute, is that a problem?
No.
No, that's normal for that. But if you don't count it and you put on your trip sheet breathing 12 times a minute, because that's what everybody breathes, 12 to 18 times a minute, and you've done no airway management, what does that tell people?
Kid wasn't breathing.
Either the kid wasn't breathing and you didn't manage the airway, or you didn't what?
You didn't get respiratory
You didn't
rate?
actually get the respiratory rate. So keep that in mind. If you hear stridor, if you hear a croupy kind of cough, a seal-like cough, that means there's an issue with the airway that needs to be addressed. You can listen with a stethoscope, both sides of the chest. So listening on a kid anteriorly is different than listening to an adult anteriorly. There's usually a whole lot more subcutaneous tissue on the adult, so you don't get the assessment that you need. But on a kid, the easiest way to listen to a kid is to have mom, or a small kid at least, have mom put the infant over her shoulders, and of course you don't want her to pat the back. That's the normal thing, is to pat the back, and listen while the kid's looking away from you. He doesn't see you coming at him, so he's not upset by that stethoscope. Okay, whatever you have to do is what you need to do to get that assessment. Assess for peripheral perfusion. Okay, you can feel the brachial, the femoral, and the peripheral pulses. Basically, what's the best indicator of perfusion on a kid?
Cap refill.
Cap refill. So, and you don't even need to do a nail bit. All you have to do is blanch the skin and see how fast it comes back. That's the best sign of perfusion. Kids don't have all that underlying disease that adults have, so their perfusion should be pretty good. You can take a blood pressure reading if you want in kids. That's assuming once you get that number that you know what. What's normal for the kid? Do you know what's normal for a 3-year-old for blood pressure off the top of your head? No. So does that number do you any good? So it's all about perfusion. Think about the perfusion more than the numbers. The biggest problem with kids, with pediatric patients, the size range is so wide. An infant, ever seen an infant blood pressure cuff? It's like that big. How many of you have that in your ambulances? Do you? How often do you use them? Not often, right. So you got to think about that as you're doing it. Think about other ways of figuring out the perfusion than just the numbers. We're really obsessed with numbers. Got to get a number to put on that box in the trip sheet. But it doesn't always work to your advantage.